Thank you, Cha, for the introduction, and thank you, Lara, as well as AeHIN for inviting me for this session. I hope you can hear me well. And can you see my slide already?
Yes, Dr. Ismat.
Great, wonderful. Okay. Okay, so I'll be presenting. So I'm actually from the Ministry of Health of Malaysia at the Planning Division. We have a specialized center called Health Informatics Center that looks into the data and information as well as data and information collected at the national level. And because of that, we need to do a lot of data sharing. Do I need to start my video? Okay, all right. So because we do a lot of data sharing, data collection from various healthcare facilities, public and private sector, and also from different division, we also manage the health informatics standards. So the data standards that allow people to actually communicate in a single language in terms of computer systems. So I'm going to start off on three basic contents. All right. I'm going to talk about what's the definition in terms of clinical terminology and how it relates to the healthcare context. I'm going to share you some examples of the clinical terminologies and the benefits. So I'm trying to present within 30, not more than 40 minutes. So we have time to ask, do a question and answer, because sometimes these topics can go very deep, or it can be for different roles. So sometimes clinicians have their own questions, developers have their own questions, national bodies have their own questions. So I'll try to leave some time for us to have that, question and answer. So I'll try to stick it to 30 minutes of presentation. All right. So let's get to basic. I love to go back to basics because once we understand the basics, then we can understand the bigger picture and the more complex discussions and complex items. All right. So I want to start with what is a terminology in the first phase. Right. So what is the terminology in terms of healthcare? So terminology is actually a set of designations and concepts belonging to one domain or subject. Very short definition, but this definition is actually taken from an ISO definition. So you can see here, I actually quote two ISO documents. One is particularly on the terminology work and terminology science. And then the ISO 704 is on the principles and method. So I'm going to break this down with you. Okay, so what does it mean when people talk about concept? When people talk about what is terminology, what is concept? Okay, so I like to give an example. So imagine if I talking to you and I'm trying to describe something, an idea, right? A concept is like an idea. And I say that I'm talking about something with roots in the ground, and that something converge into a trunk and it give rise to many branches with colorful leaves at the end, right? So once I describe this, I think everyone can have some sort of idea on what it is, right? So I can you guess what it is? It's quite easy.
Oh, your slide still on the definition of the terminology. Do you change
Ah,
any slide?
okay.
Oh, okay.
Right. So what I'm talking about is
The concept.
probably a tree.
Yeah.
Right? So that's the concept. The tree is the concept and idea. But from one language to another, you can actually say in different ways,
Uh,
right? In different language. So I say tree here because I'm trying to convey in English. But in different countries, they have different terms to describe the same thing, right? And within that concept, it has its characteristics. Right? So that's why they call it designation or characteristics, or some people call it attributes. So for each concept, for each an idea that you have something in your mind, you have something to represent it, and that's a term. So a terminology is how to represent that concept. And you've got the attributes or the characteristics, and you've got a specific definition for it. All right. So in terms of why they call it a term, because the term is relates to language. But sometimes concept doesn't always have to be a term. It can be a symbol. Like for example, if someone is audio impaired, right? They are deaf or mute, then they have a sign language. That is also a concept, right? So if we understand what this pyramid, how it connects, then it's easy to understand what is terminology. So when we go to the concept, so each concept have their own children, right? For example, you can have an apple tree, an orange tree, which is a children concept of that concept tree. And then you can also have, so this relationship is called the is-a relationship. So it creates a hierarchy, right? So, and then you can have, like, for example, other fruits, for example, strawberries. So it's not really a tree because it's kind of like a bush, but it shares a parent concept. And a parent concept is probably like a plant, right? So I remember this subject when I was like, I think grade 4, when I was when I was still a child, like learning in school about classifications, how to classify things. So basically, this is the basic concept of a terminology, how we represent the real world. And if we choose the domain in healthcare or in health, right, we can actually use the same method, the same principles to actually create this structure on how we represent the healthcare and health. Like for example, if I have an ischemic heart disease, an ischemic heart disease is a heart disease, and a heart disease is a type of disorder, right? And you can have other types of heart disease, which is a sibling concept, like cardiac arrhythmia, valvular heart disease, and so forth, right? So if we understand what concept is, what is terminology, I think it's easier when we dive deeper into the specific examples like SNOMED City, how SNOMED City is being designed, how ICD is being designed. So these basic principles is what I want to share with you early on. Okay. And then not only that, we can have multiple concepts that somehow related to one another, but not really within the same parent and child hierarchy. So for example, if you have a heart disease, you know that the disease occurs in the heart. And the heart is not a disorder. A heart is a human anatomy, right? So how one relates and one concept to another concept is also part of that terminology, how you create that structure. So here you can say that ischemic heart disease is a heart disease, but it also has a relationship to the heart via this a relationship called has anatomical site of. So ischemic heart disease has anatomical site of the heart, and the heart is a human anatomy, right? So if we can understand that, I hope we can, it's easier to talk about later when we talk about SNOMED and ICD and LOINC, all right? So if you want to try, we can also try this example. So for example, if I create a new concept called heart valves, right? So a valvular heart disease is a heart disease, but what kind of relationship would you have toward heart valves? It cannot be an is-a relationship, but it can use this kind of relationship. It has an anatomical site of the heart valve, and heart valve is part of the heart, and heart is a part of human anatomy. So as you create new concept to translate your idea, or a clinical procedure or a clinical disorder. Terminology work is about positioning that concept where it is most suitable and at the same time create a logical structure, right? A logical structure so that you can understand and it makes sense. And how it relates, why is this important? Because once you translate this into a computer language, then you are actually teaching the computer logic. If you don't have this logic, then the computer just take the word as it is, the term as it is. So every time if I want to create a new concept, I can say that, okay, heart valves is actually a type of heart disease and is actually a type, heart valves is actually a type of, a part of the heart. Then the computer knows where it is positioned, right? And this is very important when I talk later about the AI, right? Because AI is also built on relationship, but that relationship is not based on this logic, right? So, I'll save that later in the end, okay? Okay, all right. So, like I said before, terminology work is the work concerned with the systematic collection, description, processing, and presentation of concepts and their designations, and in this case, in the healthcare domain, right? So you can have a concept, all the different concepts under disorder, human anatomy, the different concept for procedures, how you're going to tell the computer these are clinical findings, these are microbiology organism, and so forth. And there's so many of them, right? So with that is the first part of my talk. All right. So I hope we can have the same base before I move on to some of the examples. I forgot to add here ICD. I'm sorry. I'll edit it later. But here, this is where I'm going to introduce the examples of those terminology, the clinical terminologies, and how one differ from one another, but how one actually share the same definition. Why are these called terminology? So an example that's commonly used in healthcare is SNOMED-CT, LOINC, and also ICD. Okay. All right. Okay. So let's start with SNOMED-CT. Because SNOMED-CT, I think, is more robust, but that means it's also more complex. But once you understand SNOMED-CT, you will be able to understand the others. Okay. So SNOMED-CT is this used to be called, the full name of it is actually Systemized Nomenclature of Medicine, clinical terms, but now it's a branded product. It's just being called SNOMED-CT. It's well known already. It's recognized as the most comprehensive clinical terminology. So when I say that, it's not just because I say so, or it's not I take it from the website, because there has been a lot of clinical research that compares how one discipline is represented. So if you look at PubMed, you will see people comparing, okay, so I'm in pediatrics. How much of the pediatric term are actually represented in SNOMED-CT compared to other terminology, for example. And when they compare, usually, I haven't really found, I don't know whether it's usually, but then most of the time, what I've read is SNOMED-CT comes on top. It means that its coverage of the clinical terms is really huge and really wide, right? So that covers for orthopedic, for pediatrics. I've seen it radiology, and you can see in other literature as well. Okay, and SNOMED-CT is reviewed and validated clinically. So because it is managed by the SNOMED International, which is the Standard Development Organization. The SNOMED International is the organization, whereas SNOMED-CT is the product that they are actually producing. So in that sense, they have a team that gather inputs, clinical inputs, and the team to review how to model and how to create these concepts in SNOMED-CT. All right. So as of now, well, Malaysia joined SNOMED International in 2012. If I'm not mistaken, it started in 2007 with several founding members. But SNOMED City is actually a combination. In 2007, it is actually a combination of two huge terminology, one from the UK read codes and one from the from US. So combining the SNOMED. So combining that, you've got SNOMED City. And since then, it's been used in over 150 countries. Either they use it as a member country, or they can, if they're not, that country is not a member, then you can become an affiliate. So to be able to use the terminology by itself. Okay, and I think one of the power, the additional power that SNOMED City has is because you can actually choose your preferred language, and you can build your own language as a national extension. So an example here I show down here is this one is a combination from Argentina, if I'm not mistaken, and Spanish. All right. So you can actually use a Spanish version and build on top. Either use the ABC or you can even use your own character to represent the same term. So on this, on the right side, let me see if you can see my laser pointer. Yeah, so here. So this is where you can actually build your own concept. So in terms of Malaysia, we are we have not actually created a national extension of our own. One reason is because a lot of our documentation is still being done in English. There has been local terms that we want to include, but for now, because it requires some management and some workforce that needs to maintain. So right now, this year, we're trying to find out what are the good, strong indicator for us to actually create a national extension. Maybe next year we can start, whereas this year we're going to start building up towards that goal. On the right side of the window, I hope you can see it, my laser pointer. Remember when I said about the concept, the parent and child, the description? So here is how you can browse SNOMED City concepts. You can go to this website, all right? Just accept the terms and reference. It's not a problem. Choose an international or one of the national extension. And if you look here, you can choose one concept, you can choose one disorder that you want to explore. And here, the first part is where the concept is, right? So the concept here is called excision of appendix. So that is the term that represents this concept. An excision of appendix is a procedure, right? And each of these concepts is represented by a unique ID, right? A unique ID. And below that are all the different ways of presenting or the terms that can represent the same concept. So in your clinical notes, you can say appendectomy, and the computer will know that it will refer to the same concept. You can say appendicectomy, which is more UK, appendectomy is more US, or you can write differently, or you can even add your own language, and that is called synonyms, right? The synonyms will represent all the same concept, and that concept have two parents, and it can have many children. right? So children are the sub-concept. So if I want to say, find me all the cases that all the cases with excision of appendix or appendicectomy, right? How you can ask the computer to actually not just search this term that's been coded with this number, but all the children concept. So previously, if I had to, we do, for example, ICD for diagnosis. So if I have like appendicitis, and if I want to find out all the diseases of the appendix, I would actually have to identify all the different concepts and codes for the disease of appendix, right? But for SNOMED-CT, because it has that built-in logical model, you can actually teach the computer to actually do this for you automatically. So this is the is-a hierarchy or the is-a relationship. And on the right to the concept is how this, the main concept, which is the excision of appendix, is related to the other concepts in the tree. So for example, for excision of the appendix, it uses the method excision, and the procedure site is directly done on the appendix structure. So if you read this as a whole, then you can actually understand what excision of appendix means. Right? So that's how SNOMED-CT is being structured. Okay. All right. So another one, like I said before, I have been talking about, we can teach the computer to do all this is because SNOMED-CT is built to be computer readable, right? But it is also human interpretable. That means us human can understand by reading the terms and understand by looking at the model and how it is being designed. Whereas computer, they have a different way of reading things in a more optimized way. That's why they usually use codes like this, and the developer, the computer system developer, need to understand how to implement this in the system. Right. That's why it's very important to me that to create this awareness is not about SNOMED-CT is not just for the developer to understand. Because if you want to develop a system, if there is no demand from the clinicians, if there's no push factor from the ministry or from the high level, then there's no reason why the people who develops the system wants to actually implement and use SNOMED-CT within this their own electronic medical record or their own analytic system. So the demand must come from the clinicians. That's why the clinicians and the managers need to understand SNOMED-CT, but from a different perspective. But as a developer, when they know that there is a demand, then they need to also learn about SNOMED-CT from their own perspective. Okay, and SNOMED-CT, when people always ask me, SNOMED-CT is not a software, right? So it's a terminology. It's like the dictionary that you put and that you teach in to the computer, right? So the computer, you can design it in different ways. You can design the interface to capture the data in different ways. So this is a slide that I've taken from the SNOMED-CT foundation course, which is a course that is highly, highly recommended. You can finish the course within 3 days from morning, daytime work schedule, 8 to 5. You can finish it within 3 days. That's for sure. So this is one picture that I like to actually reuse, because it shows that whatever interface that you build to capture clinical information, for example, it could be a smart one, you don't have to complete the whole sentence, but it can already give you a drop-down list. Or you can have a system that you need to have like checkboxes, or a clinical system, a system that actually can read the text with AI scribe or AI natural language processing. Or it's a drop-down list, or even if it's a button, radio button, right? However you design your EMR, if behind it you design it with SNOMED City, it will always capture the same concept. And because it is the same concept, then you can become a standardized way of capturing the data. And once you standardize it, then you can share it, you can reuse it, you can analyze it much easier, and you can do a lot of advanced ways on really utilizing that information, that clinical information. Right. So later I will talk about those benefits that you can achieve by using clinical vocabularies or terminologies like this. Okay. So that's about SNOMED City, and this is the learning platform that is highly recommended. So even though there are courses that are tailored for certification, so if you do a foundation course, you can get certification for that. Implementation course, if you want to really dive deeper, implementation is a 5 months course actually. And authoring course is actually for the nations or NRC who wants to develop a national extension, right? So those are courses with certification. But if you just want to learn and learn based on tailored to your group of different peoples and different groups of people. So for example, if you have clinicians, there's a tailored pathways and slides presentation just for clinicians, right? There are those specific for developers, and there are those for data analysts. And if you need, you can also, there's a learning pathway specific for translators. Okay, so you can discover more in this platform, right? If you have question, I'll save it to the end, then you can ask me question there. All right. So let's go to the second one. So the second one is a very well-known, also long-standing terminology that has existed for the clinical world or the medical healthcare world, which is LOINC. So LOINC stands for Laboratory Observations, Identifiers, Nomenclature, and Codes. Okay, so it's a mouthful, but usually people call it LOINC, and it is very famous. Why the laboratory is there is because it's very famous for ordering laboratory tests, right? But now it is much bigger. It's not just for laboratory testing, and it also measures clinical measurements. So for example, coding blood pressure, height, weight, and so forth. Those are types of measurements. Health observations, now even radiology findings and tests, right? So those are some of the examples of concepts that are being represented in LOINC. Now, LOINC is actually developed and maintained by Regent Street Institute. That's in the US. They do provide free access. Compared to SNOMED, you do have to be a member, whether a country member or an affiliate member, right? And it is being adopted in more than 170 countries. And often they are being adopted together with SNOMED City. Because for example, Malaysia, we use LOINC to create a national map for laboratory information system. So I'm sure the same as you, different states and different hospitals have their own laboratory information systems. They have different vendors and different machine analyzers, even for full blood count. So to share that that data, or even to request. Some hospitals are very small. They don't have certain types of testing. And when they want to order a test in another specialized center or a bigger center, this is where it is very important to use the same terminology if they want to request it via computer, right? So we are creating a national maps that actually map our existing laboratory information system to line code, but that is mainly for ordering the test, whereas the result of the test, for example, high blood pressure, low blood pressure, or high troponin, low troponin, and so forth, that the result or the representation of it is done in SNOMED. So that's why you can see here a lot of other countries are doing the same thing. They usually use LOINC and SNOMED hand in hand. But LOINC is actually a bit simpler in terms of how they structure the concept. It is a simple parent and child hierarchy. It has 6 attributes, or you say for each concept, it has 6 characteristics, right? But it doesn't have that attribute relationship to other concept like SNOMED. So if you remember the tree, it doesn't have, from the disorder to human anatomy, it doesn't have that relation to other anatomy. So it's very simplified in that way. So an example here so I give you an example, porphyrins panel, because porphyrins is not a usual test. If this test is indicated from a small hospitals, they probably have to, order it from a bigger hospital or a specialized center. So in the line code, it's represented by you have this also a unique identifier to represent the concept, right? So this is the full term that represent that concept. And it has that 6 characteristics to give a description to define the concept. And under this panel is the individual test, right? So for example, if you have a full blood count panel would have individual tests, like for example, white cell count, red blood cell count, and so forth. So each one of this also has that 6 attributes. So LOINC is in that sense. So you can actually explore it. They also have a browser. So you can explore some of those laboratory concepts if you want to make it easier for you to understand. And you can also discover other concepts related to orderable, such as radiology, other than pathology. Okay, so that's LOINC. And then I also want to touch about ICD-11. Right, so ICD-11, why I want to touch ICD-11? Because it is a terminology. In a sense, it is a terminology, but it is very specific for diagnostic. It's for diagnosis for morbidity and mortality statistic. So LOINC is like more catered towards the laboratory, pathology, radiology testing. ICD has been the basis for diagnostic statistic reporting, right? So as you know, it's managed by WHO, free access, clinically reviewed and validated as well. So what's the difference between ICD-10 to ICD-11? ICD-10 compared to its predecessor, ICD-10, ICD-11 now is computer readable. And not only is computer readable, it is much more enriched in its design. It is not as complex as SNOMED City, but it was set up to gear towards that more complex, more computer logical base. So, but it doesn't have that very deep logical design towards the use of ICD-11 because it is mainly used for statistics, right? So here I'm sharing with you that now ICD-11 can support multiple parent Before, it is only one single parent, right? So for example, here you can see on the right side, it's very top down. One single parent, many child, one single parent, many child. Okay. But for statistical purposes, they have created what they call linearization, where you only have a single parent. And the reason why is because still they need to fit into the purpose of ICD-11, which is for statistical reporting. And if you have if you do statistics, you have to avoid double counting. If you have double parents, most likely you can have double counting. I'll give an example what this means. So linearization, actually it needs to be mutually exclusive. So for example, if I have a bacterial pneumonia, right? A bacterial pneumonia. So a bacterial pneumonia in ICD or in ICD-11, if you look into it, it is, and using the linearization, it is a disease of the lungs, right? And it's true, it is disease of the lung. But if you look into SNOMED CT, it has multiple parents because not only it is a bacterial of the lung disease, but it is also an infectious disease, right? So if you want to do statistics, you cannot have two parents because then statistics has to be, when you add everything up, it has to equal to 100%. But if you have one concept, bacterial pneumonia, it's if you have two parents, one under the lung disease and one is under infectious disease, then you'll be counting as two cases, which is not true, right? So that's why ICD-11 has this linearization where it fits the purpose for statistic. But at the same time, it does have that, what they call the post-coordination. It has that additional concept to help you define further. So for example, laterality. If you have breast cancer, before in ICD-10, you probably have unilateral or bilateral, right? But now you can actually indicate whether it's on the right, on the left, or if you want to say bilateral or even unilateral, right? So there are additional description that can help the code to be much more specific, right? And the coding tool also allows a lot more terms to describe the same concept. So they add on synonyms. So for example, you can see here. So if I search diabetes, right? So if I use the ICD-11 coding tool, if I search for diabetes, I can have all these drop down potential concepts that I can choose, right? And then I can actually press on the plus sign to make it more detailed. And in a way, I can actually describe it further to make sure that it fits my definition, right? And then I can choose whether additional information. So patient not only have diabetes, but they have diabetes retinopathy. And that diabetic retinopathy can be bilateral and has severity of moderate. So you can see the main code is 5A14, but you can have additional code to describe it further. Okay. However, so if Malaysia has actually implemented ICD-11 starting 2024, that means we've transitioned all our data collection and our reporting into ICD-11 since January 1st, 2024. However, our reporting mainly use domain code. Even though we capture the entire description, but we have not actually looked into how to fully utilize the additional code in ICD-11. So maybe in future, there will be more studies on how we can utilize this further. Right? So just a little bit more 2 more minutes, I think. Why do we need clinical terminologies? So I just want to share with you that if you look into how the patient flow, basically that's how the data flow, right? So if you follow a patient journey, each of this process is where we need to capture the data, we store the data, and then once we store it, we either reuse it for the next visit or for the next place, for the next station, or for the next hospital, or for any place that we refer to. And we reuse it whether we share it with other information system, or we reuse it in a way that we analyze it either for research or for policy making, right? So it's either we use it internally or we reuse it externally, right? And why terminology is helpful is because once we start sharing and analyzing, that means we need to interact with other entities. So imagine if you need to talk to other hospitals, other healthcare facilities, other countries, other division in the Ministry of Health or outside of the ministry. So for example, we share data to the Department of Statistics in Malaysia. They're not in Ministry of Health. They take care of the registration of death, birth, marriage, and all that, right? So we share it with them. So if we don't have the single or the same language, that means we need to do a lot of mapping. So if you use this formula, if you need to share with 10 entities, we need to have 10 individual mapping, right? So that's not even back and forth. That's one way of mapping. But if you have a single language to represent, for example, SNOMED City, right? That means there's only one map that each entities, not even map, if they're built this SNOMED City within their system, then you can talk between the different entities straight away and share that information, right? So once you standardize the clinical terms using a terminology, you can share the data, you can analyze the data, and that's how one way you can reach interoperability within the digital health ecosystem. And why I use the digital health ecosystem is because interoperability is much more richer if it's being shared, not just within an institution, but across institution and even across regions, right? So once you can start sharing that data, and of course, we do need to look into how to make sure you protect the data, make sure it's secured, make sure this privacy is secured, is ensured, right? But once the foundation of the privacy and security is there, then you can see that it can actually use for continuity of care. And once patients have that information within their hands, then you can start to have self-empowerment. You can improve efficiency in managing healthcare because now you can have a complete and accurate patient information, of course, depending on whether the patient wants to share that data with you. And in Malaysia, we recognize that we actually have a lot of duplicates on laboratory testing, radiology testing, every time patients go from one facility to another, right? And if we can share this information, we can actually save a lot of money as a nation and make all this treatment faster. And since we can use it, we share it not just from the patient perspective, from the hospital clinic's perspective, then we can also bring it to the higher level. We can reuse it for strategic planning and research. All right. And people always ask me how, if I use ICD, why do I need to use SNOMED? If I use SNOMED, why do I need to use SNOMED as ICD? Do I still need to use LOINC? But I use DRG and so forth, right? So here is where I like to share on how these different terminology are actually related to one another, right? So as a terminology, they are much more they are much more grounded. They are actually representing the term. As for class, when you use ICD, even though they are trying towards to have that logical structure, but when it comes to statistic purposes, it is actually still a classification. So it's you basically classify or group the different terms into one group of a diagnosis or group of classification. And then if you group the classification even further, then you've got those DRG, disease-related groupings, and also another one that's also being used, global burden of disease, but not really usually being talked about. Okay, so that's how one terminology relates to another and why different ones have different purposes. And there may be at the moment, I think is where we need to use them together. It's not something that, but of course, there are cases, for example, Belgium, who have decided to use domesticity as the base terminology, and then for recording purposes, and they've eliminated recording in classification or grouping. The classification and groups are mainly used through mappings. So that means that all their EHR will be using SNOMED city, and only for statistic, that SNOMED is going to be mapped to their preferred classification. And I also like to share this slide on how not only how semantic standards or terminology are being used, but how it is also being used together with the syntactic data standards, basically how that data and information is being sent from one to another place. Okay, I think you guys, I don't want to elaborate much on this, but this is actually, if you have time, you want to take a look at it. There is actually this is a publication by Semino in 1998, and who have created a list of characteristics of how you define something as a terminology, right? A medical terminology. And Semino actually reviewed these 10 characteristics in 2006, and the output of that is he says that all these are still relevant. Of course, some people say that to be an ontology, which is even more complex than a terminology, it needs to be much more have much more characteristic. But these 10 are enough to define what is a terminology. So, for example, it has to have a concept. The concept must be permanent as a unique identifier. It's unambiguous. There's no duplication. It can support multiple parent, polyhierarchy, multiple parent. It has a definition. Formal definition means it's a logical definition. It has that logical structure. And it has different levels of granularity. So you have that children concept. It is context representation. So for example, if someone notes down diabetes, is it the patient who has diabetes, or is it a family history of diabetes? It has context. It supports synonyms. That means multiple ways to describe the same concept. And there's a way to version and audit it, right? So those are the desiderata. And my last slide is where you can explore how the different terminologies are being used for AI. Because if you know, AI is like you can dump the whole text into a large language model, and the large language model will learn on how one word is related to another. But one word relating to another is not always correct, right? So including ontology or including terminology within a large language model basically teaches the computer to understand what is the correct representation, not what is whatever they've given and feed into. So these are some of the examples that you can read on how AI is being used for not just for our clinical documentation, but also being used together with the terminology and the standards. Right. So that's it from me. I actually exceeded more than 30 minutes. I'm so sorry.
Thank you for that comprehensive presentation, Dr. Ismat. Before we take questions from the participants, we'd like to invite Liara to share her thoughts or maybe updates from SNOMED International.
Well, that was a great presentation, Dr. Ismat. Thank you for that. I'm sure that will generate a discussion, so I don't want to take away too much of the time, but I'll share my screen, and I just wanted to show you a few things. Are you able to see my screen?
Yes.
Okay, so firstly about the SNOMED International, as Ismat mentioned, we're an organization that manages SNOMED CT, which is the actual clinical terminology on behalf of all the member countries. So here is a map of usage of SNOMED globally. I'd like to hone in a little bit on Asia Pacific, and we have a growing number of countries who have joined and are in the process of joining the membership, which basically means that it allows coordinated use nationally of SNOMED in the country and enables free of charge access to SNOMED CT as well. Additionally, we also support free access to research institutions in other cases. I also would like to highlight an upcoming event that will be taking place in our region. This year, we will be holding the global conference called SNOMED CT Expo, and it will be held at the end of October from 21st till 23rd in Sydney. And it is a great opportunity to learn about the best practice of use of SNOMED, as well as clinical terminologies more broadly, as well as implementations and latest developments in various areas, including AI and research and so on. It is well attended. There will be different countries as well as different stakeholder groups, starting from government researchers as well as vendor organizations. For those who are already exploring SNOMED use and have something to share, I just would like to highlight that there is opportunities to submit an abstract of your work. These are the program streams for the conference. An abstract is due by end of April 27th. And if you're interested to share some of your experience, we would welcome you joining us in person if possible, and sharing that expertise with everybody. So if you have any questions, then please let me know. I'm happy to answer them.
Thank you, Liara. We have a question here from Dr. Aminul. So does ICD-11 only stand for disease classification, or it's aimed to cover more than that? As far as my understanding, it covered clinical conditions or symptoms as well. If this is the case, does it overlap with other terminology standards like SNOMED CT?
Let me try to answer that. So that is correct. ICD-11 focus on the disorders, but also clinical conditions, like for example, documenting the signs and symptoms. Like if you remember, the rules for ICD-11 is if you don't, at the end of care, if you cannot identify the disorder, then you should document what is the signs or symptoms that the patient presented with, right? So, however, that some of those concepts, I'm sure, will overlap with what is existing in SNOMED CT. But remember, SNOMED CT, the overlap is only on certain terms. SNOMED CT is much more bigger than that. And it covers like the human anatomy, the procedures, the medications, the substance, microbiology, and so forth. So it's much bigger. And number two, it has that logical representation, the logical model, so which ICD-11 doesn't have. So for now, if you want to, for example, gather how many patients have heart disease, for example, you would probably have to find a way to do that outside without, because it doesn't have that logical model built in. Whereas in SNOMED, if you use SNOMED within your computer or electronic health record, then you can actually create that queries or that question to extract the data just by using SNOMED City logical model. I hope that clarifies.
Thank you, Dr. Ismat. We also have a question here from Dr. Alvin. So what might be your advice to countries just about to start their SNOMED journey, and what are low-lying fruits?
I think for the past 5 years, I think SNOMED has actually created a toolkit on onboarding toolkit, right, Liara, for new members, which is very helpful. I can share the link here for everyone can see. And that onboarding is very helpful, where it's set up the National Release Center. So, for example, as a member country, one of the biggest benefit of a member country is anyone, whether the facilities or the developers within that country who wants to use SNOMED, can use it freely, right? So they can actually implement anywhere, how many times, in hundreds of facilities freely, right? Number 2 is, when you become a member, you need to identify who will manage it as the National Release Center. And I think as a country, one of the advice that I was discussing earlier in the talk is actually identifying who shall be the National Release Center is very important, because the National Release Center is the coordinator between the country or the representative in the country with SNOMED International, right? So, for example, not only for creating a new concept or asking about training and all that, asking for help and doing events, is usually through the National Release Center. And the function of a National Release Center, you will see, differ from different countries. Some countries, National Release Center or NRC, act as only a collaborator. So their role is only to collaborate all the requests of, like, for example, new concepts, new terms from the different division or different vendors, and then they will take it up. Some NRC is an implementer themselves. So, for example, Malaysia, for us, we are also the NRC who give access for those local who wants to use SNOMED City, but we also develop our own project to implement SNOMED City for AI, or for natural language processing. So, but once you identify who will be the National Release Center, then that National Release Center can create a roadmap, or at least identify what are the roles and responsibility that they want to take up, and then what are the roles and responsibilities for those under their jurisdiction or under their group.
Thank you, Dr. Ismat. We have a few more questions here. I hope it's okay to extend.
Yeah.
We have a question from Pa Anis from Indonesia. For a country trying to have a transition from ICD-10 to ICD-11, what will be the mitigation strategies related to the updating the DRG with the ICD-11?
Transitioning from ICD-10 to ICD-11 is a huge effort. We actually took 2.5 years, 3 years to actually plan ahead. So we planned since 2020, but that because of COVID, we started in 2021. And then the pilot started in 2023 with full implementation in 2024. So even in 2021, we know that it will affect the systems, right? The computer systems. We need to update the computer system. So not only the centralized systems that collect the data from various facilities, but also how we're going to handle the different facilities, right? So because in we have in Malaysia, we have the Malaysian Health Data Warehouse. That is a centralized repository that actually collects this data from various sources and also produce the report. We change that system first with a backup plan and a strategic plan to make sure that all the contributing facilities are actually will transition to ICD-11 in future, right? So even though there are hospitals that are using legacy systems with ICD-10, we actually created mappings that is fully integrated into our system. So they are sending data into from ICD-10 into Malaysian Health Data Warehouse, and we will convert it to ICD-11. And that exercise itself is actually quite huge, creating the mapping. And we have committee members to actually review and validate that mapping. So that's in terms of system, number one. Number two is the training, right? The training. So the training for ICD-11, but I would have to say the training for ICD-11 is much more easier than ICD-10. So for Indonesia, if I'm not mistaken, you include ICD-10 syllabus within your medical students curriculum, which is huge. I think that's a very great effort. That means because you want the doctors to enter the data themselves, right? To codify, right? So in Malaysia, it's a bit different. We have to transition because we have medical record officers who codify. They are not doctors, but now there are more and more doctors who does the codification themselves. So in your setting, I would say that the training from the university has to update their syllabus, but the training is much easier because WHO provide the tool to train. They have the syllabus to train. They have so you just need to follow the step of training that they recommend. And for us, it used to be like 5 days of training for ICD-10 with the 6th day of exam or certification. With ICD-11, it only take 3 days to cover. So that's training. And then, of course, number 3 is the national reporting. The national reporting, a lot of the reports we need to update. How we're going to classify based on the ICD-11. So I think those 3 are the major ones that you need to think about, the systems, as well as the vendors, if you have the vendors. Number 2 is and if you have the legislation to enforce it, I think it's much better, much quicker for the vendors to actually implement ICD-11. Number 2 is the training. Yeah, so those 3 things.
Thank you, Dr. Ismat. I think we have last 2 questions from the participants and then Sir Jai and Dr. Bunchai. So we have a question from Mr. Naeem from Malaysia who's studying medical informatics. So the question reads, I would like to ask, is the ministry looking into AI medical scribes where the AI listens to the doctor-patient conversation and automatically translates those recordings directly into standardized SNOMED and ICD-11 codes?
As far as I know, these are the implementing the electronic health record is under Bahagian Kesihatan Digital or Digital Health Division. So in Malaysia, we have 2 different wings. One, Health Informatics Center, we take care of the data. So basically the recipient of, whatever systems in the hospitals and clinic, the electronic health record. So the electronic health record, that project is actually being handled by the Digital Health Division. I have not actually heard their plan on implementing AI scribe, but that is something that I wish they are thinking about as well. If I'm not mistaken, this year they are planning to actually implement the electronic health record in 16 hospitals and 100 clinics. So 100 clinics is actually very small. It's only like, because we have 3,000 clinics, public clinics. So it's, I haven't heard yet, but I hope they will soon. But that needs a lot of validation, I think, implementing AI in the healthcare setting.
Thank you, Dr. Ismat. So the last question is from Dr. Sharma. So is the LOINC certification available for free or does it require a paid registration?
The LOINC certification, that's available for free. You do need to register in their website. So you need to you do need to register in their website, and then even the entire terminology is you can download for free. But I'm not sure if there is like a specific training center that provides, a paid training. That's that one. I'm not sure.
Yes, thank you, Dr. Ismat. So that's the last question for the participants. And then now we'll have Sir Jai and Dr. Bunjai.
Thank you, Cha. I would like to really thank Dr. Ismat. This is a presentation that you could actually make school kids do SNOMED CT. I think you went to that level of nicely explaining. Really appreciate that. And usually we will have more participants, but then given the time which our members are used to, and then also I think some are still in holidays, but then I think a lot more will be listening to the recording. This question is like because much before India actually joined SNOMED CT as a member, like NRC started, I think it was in August 2013, if I remember right, because our hospital actually started looking at SNOMED well before that. And then at the time, the challenge was the HIS provider did not have a facility to have SNOMED CT accommodated. They had others. So the challenge was that. But then like now, like India became a member, and then NRC actually started building the capacity. For a country of that magnitude, like you have to have, pan-India workshops to create that kind of an awareness. It took few years. But then like my question for you in Malaysia is like, there should be as much support from the HIS providers to actually facilitate. Malaysia being predominantly also like a lot of private players are in place. How do you actually, do you have a mandate? Like, is there anything like every EMR vendor or the solution vendors should mandatorily accommodate support for SNOMED CT? Is there anything like that? That's my question for you. And then I will leave it to Liara for like, especially for GPS, like we have this collaboration agreement between AeHIN and SNOMED CT. Like for those who are not yet SNOMED members, can GPS form the first set of experience for them to actually do the pilot testing and then get more interested, and then of course they can kind of discuss with the governments, because subscription or becoming a national membership is in a different league than what we can technically do from AeHIN side, because it's also a political decision in that way. Just these two questions. I know we are well well above time, but I will leave to Ismat for the first question at least. Thank you.
Sure, thank you, Tijay. Okay, so mandates. Mandates are very important. So to me, there are many ways, there are many mechanisms to actually legislate or actually enforce. Not really enforce. When you say enforce, it's usually via an act or a law, right? So for Malaysia, we actually have not established a law specifically for other terminology. So for example, we do have a small clause, an act in the Medical Act that mandates reporting to the government from the private sector in ICD 10. But as we now move to ICD 11, now we're a bit stuck, right? So that is something that we are actually currently updating the act. Number two, when it comes to SNOMED CT, this is a very big gap in Malaysia, because right now we are now creating a national policy for health data standards, and that is due in June this year. And within that policy would outline have a supplementary volume for individual data standards that being endorsed at the ministry side. So we will have one volume for ICD, one volume for SNOMED, one volume for the rest. What we try to do is actually create that strategic plan, but also tell the private sector this is what they need to do. So within that plan, for example, for Snowmed City, it's actually an upcoming event with Snowmed International actually in May, where we're engaging the private sector to explain to them what is Snowmed City and how it is being used internationally and why they need to be on board. Right. So hopefully with the national policy endorsed at middle of this year, and based on that policy, we can actually take out circulars. We can develop circulars to give them to mandate the private sector to start, implementing this. So I think that's our way of doing it, because in terms of developing the legislation itself, it will take a long time. Even now, we're trying to look into creating a Digital Health Act, but the scope of Digital Health Act can be so big, so we need to look into it further before we decide what's the scope that it will cover.
Thank you, Ismat. Okay. One is like legislation or something. I was thinking about encouraging EMR vendors to basically list them, saying that, these are the vendors in the country who have already passed that kind of setting a standard like that. But, that
Yes.
encourages others to also come on board. That's what I meant. Thank you.
Yeah, that's right. So certifications of the private sector, and also accreditation, that telling people that these are the vendors that has been accredited because they have implemented these standards. And also number 3 is when we are creating a template for procurement. So within the procurement, any procurement of IT, we create a template that these are the things that must be included for any procurement of ICT system in Malaysia. So yes, thank you, Raja, for sharing that. Yeah.
Thank you.
Hi. I think before we close for this excellent webinar, I think we should do similar to this. But as the AeHIN is a network that we are knowledge sharing, we will not sharing the only the good part. We also sharing our scar as a senior in this area. I don't quite sure how many of you are being news in the informatics or the experience on that. But the politics on the ICD-11, WHO ICD-11 is, and SNOMED CT International is ongoing. Not just our region is suffer from this kind of the harmonization of these two standards. The other regions are also working on that. We hope that eventually there will be harmonizing about these two international standards. This is my personal opinion that as the 2-3 decades of the informaticians, I think for the data collection, the more granular terminology should be at the point of care, and it fit well with the clinical terminology of the SNOMED CT. For the statistic and for the reimbursement, then the classification like the ICD-10, ICD-11 is very essential, and those will be the one that can link all the business in the healthcare. So to me, we as the informatician, we should learn both. And I think those two standards will be, no one totally win this kind of the international standard. They will be coexist. But how we gonna implement it in which context, how we gonna use it is up to us. We should learn on that. So this is a very painful experience for countries that have to go through this kind of the different international standard. But no worry, conflict is everywhere. We have to learn and we have to be optimized for our countries and our regions. So thank you, Ishmat. You are really the expert and champion on the semantic terminology and others. We think we should work more on this in our regions. And we have a lot of topic that we can discuss and build our community to learn more about this.
All right. Thank you, everyone.
Bye. Thank you, Laila and Ismat, for
Bye.
this.
Thank you.
Bye.
Thank you.
Thank you very much.
Bye bye.